Hi, Dr. Dawsett.
Hi, Daryl.
Hi, thanks for being in our conference. Can you tell our audience what you do and where you do it?
Well, I'm an Emeritus Professor at La Trobe University in Melbourne, which is what would probably be called in the US a liberal arts college. Before I retired, I still am working. Before I retired, I was the Deputy Director of a research centre called the Australian Research Centre in Sex, Health and Society. And that's the largest sexuality research centre in Australia. But I also started working on prostate cancer about 14 years ago after my own diagnosis. And so we did a number of projects there and in collaboration with people in Sydney, nationally, and Canada and the US on prostate cancer during that time as well.
You know, it's worth repeating. You're a gay man who was diagnosed with prostate cancer 14 years ago, still alive, still kicking.
Alive.
Yeah. And so your insights are both personal and a product of all the great papers you've written and investigations you've conducted, both yourself and with your colleagues and such. So, you know, it's fair to say you know something. And what we're going to be talking about today is what that something is. So over the last 14 years, what can you tell our audience about like the top level concerns that gay men present around prostate cancer?
It's changed over that time. I think I could summarize it very sort of quickly and say invisibility was the biggest problem around the beginning when I started my work and when I was diagnosed and treated. Now I think we're at a further stage along where the complexity of gay and bisexual men's experiences, and to a certain extent transgender women, experiences of the whole disease from early symptoms, diagnosis, right through to living with, well and truly after treatment, are revealing more complexity than we originally thought compared with heterosexual men. It's not a simple divide between the two populations. It's more complex than that. But there are now good data showing differences that suggest we need very significant new training programs in prostate cancer and in sexual health generally surrounding prostate cancer, so that the living through and living with of a prostate cancer diagnosis is actually being treated far more precisely and concisely, rather than through a kind of general one size fits all that was largely modeled on heterosexual white married men.
So is it fair to sort of flip this around and say that 14 years ago, 12, 10 years ago, men who enjoy sex with other men, and for this conversation, we're just going to say gay men and leave it at that. The idea that, as you put it, an invisible sexual and gender minority group, was their treatment less than optimal? Were gay men with prostate cancer harmed as a consequence of whatever was going on 14, 12, 10 years ago?
The answer is yes and no. It depends on the measure. If you were a urologist or an oncologist and you were applying the same level of treatment to the same level of symptoms that you were presented with by a patient, it would look like you were treating the disease equitably and efficiently. What the researchers found, and what my own experience highlighted and sent me on this path of research, and my colleagues, was that it's all the stuff surrounding the narrowly technical diagnosis and treatment activity, all the stuff that is the living with, if you like, sometimes called survivorship. Oh, that's not a word I like. But that sort of living with the social world around you, the personal life, the body, the sexuality, the experience of it, the learning how to live again in a different kind of way. All that stuff was much more neglected for gay and bisexual men then, compared with heterosexual men. However, I must say, what shocked me about the prostate cancer field when I started working in it for all men was how poorly men were thought about all the time, all men, and how poorly men's sexuality was thought about most of the time, straight and gay men's. It was reduced to getting an erection sufficient for vaginal penetration. And if you could do that, or most of that, you're home and hosed. Nothing else was on the table. And it's really part of the struggle we've had in the last 14 or 15 years is getting a concept of human sexuality as distinct from sexual function in the focus of the way people think about treatment, care, and support. Because that's the area, the sexuality side of things, the broad issue of sexuality and sexual health is the area where people experience the most problem and where gay men were most neglected. But I must say, years ago, straight men weren't very well thought about either.
Now, what was missing 14, 12, 10 years ago that we're just beginning to understand today?
My first quick comment is the line blurring what gay and straight men do sexually is blurring more and more and more and more and more. The world is queering, if I can say it that way, in a big way. The main thing was there was no reference in my experience and in the men I interviewed in the early studies to, if you like, what I have called in the past the sexual choreography of an encounter with another person or other persons for gay men's lives. How do bits and pieces of the body fit together? What does a sexual event look like? How does it start? What's the process of working one's way through it? How are sexual activities negotiated from the point of view of asking for what you want, suggesting what you might like, coming up with new things you might not have done before, or the other person or people might not have done before? How do you present yourself in sexual situations when you're aging but still sexually active and suddenly find yourself aging but no longer sexually able because of dysfunction in some way to participate in the same kind of way? How do you deal with that? Now, none of that kind of stuff was there. I might say I don't think much of it was there for straight men either. I think a lot of medical specialists just expected their wives to lie there and let the men practice. And I really do say that not cynically. I think that's literally how women were often positioned as partners, and they were positioned as partners and carers and people who would help. And that meant help sexually. And I don't think that was very good for straight men and those women either. But there was nothing about what partners might do if they were same-sex partners. How might you negotiate a same-sex partner in some sort of a way? There was very little information on what alternatives there might be for some of the traditional practices that you might like. For example, if you do practice safe sex, and of course, gay men have had to deal with 40 years of AIDS as well. You know, when prostate cancer comes along in your life at my age, you've dealt with AIDS for 40 years as well in some way, whether you've got it yourself, which I don't, or you work in it, or it's happened to your friends or whatever. So we've been negotiating that. What do you figure out? How do you work on a condom into post-prostate cancer sex when maybe your erection is not as good as it used to be, or requires your Viagra or some other chemical of some kind to help you get there, and the effect is partial? What if you need to use a vacuum pump to get an erection nowadays? And how do you keep the condom on? Now, of course, you know, you could use a cock ring or something like that, but no one tells you any of that. So none of the detail about how sex happens, as I said, what I call the choreography of sex, is in any literature at all. There's nice little words about negotiating with your partner and learning to look for other pleasures, which are so anodyne as statements. What does that mean when you're trying to get tab B into slot A in some particular kind of way, or negotiate that in a sexual encounter with both a partner or a stranger or both? And there was no recognition that gay men's sexual lives might not be monogamous and married, which even with gay marriage, they're still not mainly monogamous or married. So that the partnering processes that you negotiate are entirely different as well. So that's completely left out. And I noticed when I did my first audit of Australian resources for men with prostate cancer, there was one booklet from the state of Queensland in the north that on the second last page, with exactly the same text, had a little photo that big of the back of two men's heads up in a top corner. And that was the only possible reference, which you could miss easily, that a man might have a male partner. The rest of the book was a man and a woman, and everything was about partners, but it was really all about heterosexual sex and heterosexual vaginal misandry position sex, not using condoms.
Yeah, and you're correct in knowing the world is queering up. When Malecare support groups start talking to each other, you hear things that doctors don't. And you know, it's like, why is that? You know, and the obvious reason is most doctors are just not asking their patients what their fantasies are and how they could fit the treatment to accommodate those fantasies and real world activities.
It requires a different kind of patient-doctor relationship. And you know, my experience, and I had a urologist who was I was 55 when I was diagnosed, by the way. And so my urologist was probably about 43, 44, very dapper young straight man, you know, but clearly a generation almost younger than me, or half a generation younger than me. He had absolutely no idea whatsoever what to say to me about gay men. When I said to him, "Oh, by the way, I'm a gay man," and like his face just went, you know, blank. No, I don't respond here. When I asked about sex, you know, he said, "Oh," and he handed me a script for Viagra.
Yeah.
Nothing more, nothing else. So I think they're not trained either. And it surprises me that the younger generation of doctors coming through may be even less aware than some of the older fellas who've been around a while and seen a few things happen. And I have worked with we're very senior urologists, both in South Africa and in New Zealand and here. And they are quite aware because they've been around a very long time. But it's the kind of technical expertise. You know, I'm going to use the Da Vinci. I'm really good at that kind of surgery now. I don't need to use open surgery. I'm going to master the technology, boys and their toys. And it seems to me like that precludes in both in training and in experience, an idea that some of the other things, the relationships around people's lives, involves the urologist too, as a caregiver. Yeah. And therefore they need to participate as a human being, not just a technologist.
You make a good point around the young doctor. The young doctor has no clue what Stonewall is. A young doctor has no clue what the AIDS crisis is, because they would just prescribe it away. They wouldn't understand it was an experiential issue as much as it was a health issue, you know, and one of extraordinary fear. So in a way, the older doctors, even though they may not have been adept at treating patients who were of a different sex or gender than themselves, at least they understood there was something in the world that wasn't right.
A bit more complex.
Yes, that's right. As you say, the young doctors are boys with their toys, and it's a playroom where there are no problems.
Sorry. Look, one of the things that struck me when I really first started working in this, and I used to throw it into my speeches for doctors, you know, I'm now 70 years of age, right? I am smack in the middle of the baby boomer generation. It was my generation in the 60s, the late 60s, that started having sex with the pill. The girls in our group would have sex with the pill. And I had an early heterosexual life as well before I became a gay man. So, you know, we were using the pill. We were having many partners. We were having group sex. We were smoking marijuana and trying a few other things as well. This was the summer of love. This was the sexual revolution. This was the beginning of feminism, the beginning of gay liberation. That's my generation. I'm not my grandfather. You know, I'm not a Methodist elder in a church who was monogamous for his whole life. But somehow or other, when you're in this age group, younger people seem to think, oh, you're like my grandfather and they're just really nice people. They don't have sex and they didn't have a wicked past. Well, the fact of the matter is my generation of men have had a pretty wicked past, a lot of them, and have done lots of things, including sex and drugs and rock and roll. And maybe that's something to tap into. I mean, it's not surprising that we're finding levels of sexually transmissible infections increasing in seniors. It's because they're much more sexually active than seniors were a few generations ago. So, you know, it's a different generation of older people that are now being diagnosed with prostate cancer than the textbooks remember.
Many gay men just won't come out because they don't want to have to deal with teaching their doctor.
Indeed.
You know, yeah.
Indeed.
Go on.
Well, we in another study that I'm working on with Jane Usher. So Jane and Jeanette Pers, her partner and colleague, are leading this big national study of LGBTIQ cancers in Australia, which I'm an investigator on as well. And we published a couple of papers. They're beginning to come out now, one of which looked at healthcare providers and how they respond to LGBTIQ patients. And we've come up with a kind of typology. This is really Jane and Jeanette's work, a typology of people who are very, very accepting and inclusive in their practice. They try and make their clinics inclusive. They put rainbow flags, et cetera, et cetera. Then there's other people who pretty much say, I treat everybody the same, which of course is actually ignoring the fact that there are differences that need to be responded to, but they believe themselves to be fair-handed. And then there's a third group, the smallest group, but the third group who are absolutely still homophobic. Now, that's what we found in this national study. Now, that probably exists in many high-income countries and middle-income countries around the world. So LGBTIQ people are still experiencing healthcare systems where there is discrimination, where there is lack of inclusive policies in place in certain cases, and also experiencing untrained healthcare providers at many levels, from medical practitioners down to social workers or the allied health field, who have had no training, even if they want it, can't access training to make their practice more inclusive, and to be exposed to a set of ideas that make them think about any residual prejudice they may or may not hold about people who are different. Now, I think this applies to all minorities in some ways, racial minorities, ethnic minorities, as well as sex and gender minorities, and people with disabilities. I mean, I think we know how this works in the health inequities field. And you can't ask every healthcare provider who hasn't had the training and the time and the money spent on them to help them become truly inclusive and reflexive in their practice to suddenly invent themselves anew because they're confronted with a patient. So what do the patients do? They manage. They manage up, basically. They don't tell, the partners aren't brought into sessions, they don't ask certain kind of questions, they go online. What did I do when I was first diagnosed? I went online and found Malecare. That's one of the things I found by searching around online all those years ago, because there wasn't stuff being given in the booklets that I was given by the nurses, the urology nurses, that gave me any answers to the questions I was asking while I was waiting for my surgery. So I think people manage like that. I think a lot of gay people get pissed off. A lot of queer people get pissed off with that. I think some of us are just kind of like resigned to it. You know, you figure out, oh, how many fights am I going to have today? I'm going to fight with the checkout person at the supermarket for asking me about my wife? Or do you just give up on some things and concentrate on the main game? But for other people, it's deeply, deeply offensive and hurtful. And it is actually damaging to the progress of their treatment. And I think that's the reason why we have to actually continue to fight for absolute equality in healthcare provision, not just technical provision, but in proper service provision inside healthcare.
Was there anything that comes to mind that you don't mind sharing, that was like a barrier within your healthcare experience?
Just no information. I went to the Prostate Cancer Foundation of Australia, which is the big umbrella organisation in policy and health promotion and research. I went to the cancer councils, which are our state-level multi-cancer organisations. These are all non-governmental organisations in Australia. I went to your website, where I did find information for the first time specifically for gay men. I came across a Yahoo group, and it was on that Yahoo group I met one of my colleagues in Canada who was also a prostate cancer patient, and we started talking and researching together and have been working together ever since. I did some thinking. I mean, as a sexuality researcher for many, many, many years, and working in AIDS all my career, where you're looking at the sexual transmission of a virus and the consequences for a sex life of treatment, I did some extrapolation from my own understanding of how gay sexuality works as to where the likely consequences might be, and then went in search for it online and to see what I could find. And doing, as an academic, I had access to search engines that will search the academic literature, which most people don't have unless you're an academic. So I was lucky there. And I could go and search on stuff. If I heard a phrase like PSA doubling time, I thought, shit, what's that? So, I go in and immediately do a Google Scholar search or, one of those other online search engines and try to track down what PSA doubling time actually means, because I didn't quite know what it meant and I was a bit confused by it at some point. So, but when it came to no one treated me badly. My urologist did not treat me bad. He was not a terrible man. He's a nice man, He just didn't know anything about gay people. The urology nurses were very nice women, all of them. They were all women. They were very helpful, but they really didn't know any answers.
Yeah. Let's drill down a bit in more practical things. We have, a patient audience, and they want helpful hints from everything we present to them.
Right.
Okay. So you have yourself, your own experience, but you also have, I don't know how many, half a dozen to a dozen research projects.
Yeah, about half a dozen now, I think, that I've been really actively involved in, yes, but others I advise on, yeah.
Okay. What have you learned that's somebody that you could share right now? What are like 5 to 10? I'll put you on the spot. We'll go for 10. What I mean, lubricate the edge of a vacuum pump, or enjoy pornography. I don't know.
Yeah,
what have
yeah.
you learned from all talking
Okay.
to hundreds of people?
And you want to focus on sex particularly?
No, on
Okay.
whatever's relevant to prostate
Okay.
cancer.
Number one, be an
And
active.
by the way, identity. I mean,
Yeah,
a
sure.
lot of our men talk about, I don't feel like a gay man
Yeah,
anymore.
yeah. Number one, you have to be an active patient. There's no point, even in the face of the most there's headmasterly urologists, and some of them can be very headmasterly. There is no point in being a passive patient. Your future is in your hands as a patient. Whether the urologist or the oncologist works on a collaborative model of patient-doctor health, that really is what's going on, whether they do it or not. And it is in your hands to take control of your treatment. And that means going and getting the information yourself if it's not coming from them, asking the questions. You can't always do everything you want. It might be too uncomfortable to do everything, like coming out or bringing your partner in, but be an active patient. Don't be passive, and don't just wait for them to take the lead on what's happening. Ask and question and find out. Number two, when it comes to recovery, and I had surgery, open surgery, and prostatectomy is still a major treatment that's used, although radiation is increasing in its use and its variety at the moment. There is always preparation for any kind of treatment, whether it's getting yourself fitter, losing some weight, doing some Kegel exercises. So if you're going to suffer from possible incontinence, and boy, did I do those Kegel exercises in that month between diagnosis and surgery. I did nothing else but Kegel exercises, it felt like, during that time. So I knew that was one of the keys to dealing with incontinence post-treatment. Do the Kegel exercises. Post-treatment, practice. Practice the Kegel exercises. Practice playing with your penis. Practice playing with your anus. Get to know your body again as it heals. It takes time, but as it heals, explore your body again as if you are learning to a certain extent how your body responds erotically to touch. I've had men in the study who 2 or 3 years outside of their treatment have said to me, I was too frightened to masturbate, so I didn't. And what they didn't realize was the spongiform tissue in the penis will actually deteriorate if it's not exercised. Blood going in and filling up the penis and expanding the spongiform that makes the erection, it will actually deteriorate and stop functioning if it's not exercised in some way. And he thought that was the right thing to do because he thought masturbation might be dangerous. Quite the reverse. In fact, if there's one word I would say to people trying to recover sexual function, it's masturbate. As frequently, as often as you can, and you like, in any particular way you need to. And if that does mean you like watching pornography, use pornography. If that does mean you like, what we call in this country, I don't know what you call them, one-handed reads, where you're reading an erotic novel with one hand and your other hand's doing the job, then it's one-handed reads. If you, it's a bit harder to practice in a gay men's sauna, because the kind of sexual choreography of one of those sex venues generally requires an assumption of sexual function right from the start. To try and negotiate in a dark room that you don't necessarily get a very good erection, but you'll do this, is a bit harder in those places. So that stops a lot of men from practicing and trying to go out to become sexually active again. But you need to kind of give yourself a sense of a plan over time, because this doesn't happen instantaneously either. It's roughly about 2+ years for many men before they really can estimate the extent to which they might have erectile problems, and just what the scale might that be on a scale of 1 to 10. It's probably a little sooner you'll find out about your incontinence issues, both urinary incontinence and fecal incontinence, because fecal incontinence can be a problem, or incontinence when you're on the loo having a shit could be a problem if you've had radiation. It could be a problem if the bowel was somehow damaged during surgery in some way. So there are issues there to be followed through with, but they will work themselves out in their own way if you apply yourself to it and find out what's the best way you can move forward in strengthening your musculature in your abdomen, in finding out what your limits might be, because there might be some limits and you just have to learn to deal with those. And the social side of this is trying to figure out what's going to be your posture, your comportment with others. It's like being in the closet or out of the closet. If you're out as a gay man to almost everybody in your life, then there's all sorts of things you can do and say and let people in on that you can't do if you're in the closet. Now, people all negotiate that their own ways. It's the same with prostate cancer. If you decide that it's shameful, it has to be hidden from the world, you're too terrified to tell people, that will shut down all sorts of both communication and social support that enable you to rebuild your life back into the world around you, the social and sexual world around you. And for gay men living and gay and bisexual men living in gay communities, our social world around us is often a sexual world. You know, some of our partners, our friends might be ex-partners. Some of our partners might be non-monogamous. And I'm going to have to stop now just for a second.
Work.
So there's a way in which the deciding what your posture or your comportment is going to be and how you present yourself as a person living with prostate cancer to the world is important for rebuilding your social and sexual life. And we have a really good, gay men have a really good model here, and that's people living with HIV who have done this all for us. You know, they got out there in the late 80s, early 90s and demanded to be recognized, demanded to be involved. You know, nothing about us without us. You know, the slogan was borrowed from disability activism. We want to have a say in what's going on. All that activism of people living with HIV, the demand for better treatment, the demand for information, and the changes in medical practice that they demanded and got all around the world, not just in the high-income countries. That's a really good model in some ways for us, for people with prostate cancer, because you know we simply had a medical condition, just like HIV, just like TB. You know, there are medical conditions in the world out there. It's like getting COVID, for God's sake. It's a medical condition. It is not a sin. It is not a sin to get COVID. It is not a sin to have prostate cancer. It is not shameful. It's just something that happens. And getting out and about and being there. And I suppose I was very lucky as a very well-known out gay man and researcher in this country. I went straight out with prostate cancer. Straight away, I went right out there. First research projects, applying for grants, working with our local AIDS organisations, the Prostate Cancer Foundation. I put it all on the table. I had a good model from gay activism about how I could behave as an out gay person with prostate cancer. Now, not everybody can do that or have a working life that enables you to do that. And I was very fortunate that my university was unbelievably supportive of the work that we do on all of this stuff. But there are other ways you can do it in your own world, your own friendship circles and your networks, where in a sense you almost lead by example, because you suddenly discover that one day that someone knows that, and this has happened to me a lot, when I was out there doing stuff and saying to people, suddenly I got friends coming to me and acquaintances of friends coming to me saying, I know you've had prostate cancer. Could I talk to you about it? And straight men coming to me and saying, I know you've written this. I was given it by somebody, my first little piece that you know. I've read that and I want to talk to you about some stuff that I'm not getting any information from my doctors. And I can't really ask my female partner yet because I'm not sure what this means. So can I ask you as another man who seems to talk about these things? So you can, there's real benefits from taking those steps. It takes a bit of courage to get out there and learn to engage the world as you are, not as where you once were, and not as how you would like to think you will be again, because we might never be the same again. But there's benefits to be gained from going in that direction. And if you couple that with all the practical tips about practice, try new sexual, try toys, try sexual aids, try vacuum pumps, you know, use more lube, use cock rings, investigate all the alternatives. What is important to you? If you're a top, can you flip to a bottom? Most gay men are versatile anyway. So, you know, what does it take in your head to do that? If you can't, what's the alternative? What can I do elsewhere? What's possible? what are other gay men doing? And sometimes gay support groups for prostate cancer are good places to take those kinds of questions, because like your Yahoo group, there were some really right out there in your face questions on that chat group that you wouldn't get asked you wouldn't ask in a doctor's clinic, but they were talking about it. And I found out a lot for what those guys were actually saying out loud to other gay guys on that chat group. So gay men are often very good at talking about these things, but you won't talk about it with someone unless you tell them that why you're interested in that. Well, how's that? Is that 10 already?
It's I think numbering these things is irrelevant. It's powerful and useful. Just a couple of more thoughts around this, though. I mean, I'm thinking of the sad things I've heard over the years, and there are many. One category is that prostate cancer takes away my identity as a gay man. What can you share around that?
Again, we've had really interesting parallel experiences in the early days of HIV with exactly the same issue, that becoming infected with HIV, particularly in the days before there were any treatment, so right up until the mid to late 90s, so nearly 20 years, men living with AIDS, as it was called in those days, now living with HIV, would often find themselves kind of excluded from what was mainstream gay, or feeling that they must be excluded from mainstream gay. There was one great magazine in the States that was called Diseased Pariah Diary, I think it was called, and it was for HIV positive men feeling like they were diseased pariahs in the gay community, not welcome, not wanted, discriminated against. So we learned a lot from that experience about where identity connects with these kinds of things, and how different it was in HIV to have your identity permanently welded to the situation of being HIV positive. You can get syphilis and be cured, and you're not syphilitic, because you can be cured from it nowadays. But with HIV, of course, they can't be pulled apart. And the same is true of prostate cancer. You can't, once you're in this game, you cannot pull it apart from who you are. You do have to develop a new version of who you are in some way. There is, just like people with HIV learned and demanded to retain their identity as gay men and proud gay men, the same thing is for us to do. That there is now generations of gay men stretching from 15-year-old queer kids all the way up through to 90-year-old, pre-gay liberationists, all living in this world at the moment. We're not all 30-year-old people hanging around, the West Village. There's a whole array of us, and we all have a place in this thing that we've created called gay community, but we only keep it if we demand it, because we created it in the first place. So it is about being out there, demanding services of gay organisations, demanding recognition. I haven't seen in the Sydney Mardi Gras yet a group in the parade saying gay men living with prostate cancer, but it's one of my dreams that one day there might be a float in the Mardi Gras when we have them again, waving the flag at prostate cancer. But the Prostate Cancer Foundation does actually turn up at a number of events in Sydney Mardi Gras and in Melbourne Fair Day, and have stalls for gay men and float materials for gay men. So it's there, but it's not at the point where you can have 10 drag queens on this float and 10 guys with prostate cancer on the next float, but it'll get there. But it's up to us to get ourselves on that float.
Yeah, and what might that float look like? Walnut necklaces. I don't know.
Well, I don't know whether whether we decorate it all in blue ribbons. I'm not sure about that, because that tends to be the thing. But I suspect, given that people can, I just read something this morning about a person diagnosed at age 45 with prostate cancer. So it can happen. Yeah.
Well, no, our earliest was a guy with biopsy confirmed prostate cancer at age 27.
27.
One of our board members was diagnosed and treated at age 32. And changed his life from being a Wall Street guy to he's a doctor now. Because just to finish, so
it is part of being what is being, let me call it queer for want of a better word than gay here. LGBTIQ represents a really broad church of identities nowadays in sexual and gender minorities. It's a big unwieldy acronym that covers a lot of things, but essentially the one thing it recognizes is the diversity within the diverse. or the diversity within the marginal, or the non-included. And the other kinds of diversities exist, including issues to do with health and issues of having had cancers. Lesbians surviving breast cancer are facing exactly the same struggle in some ways inside their own communities to be recognized. They get a bit of a better run at times because breast cancer is a feminist issue, whereas prostate cancer hasn't quite positioned itself in men's health in the same kind of way that breast cancer is positioned in women's health. So we're a little bit behind in that field, but visibility is what will make it different and enable all of us to feel like our identity is not compromised. It's been renewed and changed. And now I'm living as a gay man, an out gay man living with prostate cancer. That's my new identity in some kind of a way. It's not the only thing I am or the only thing I do, but it's part of who I am now. It will never be other. And
Dr. Dawsett, thank you for your insights and for doing the research that you were doing. Getting funding for that was probably a big struggle many years ago. Yeah, and still is in many places, and we're fighting to make that less apparent. Yeah. One last thing around blue ribbons, though, the idea that we're basically a queer nation of prostate cancer patients, of people diagnosed with prostate cancer. I don't know if blue's really the thing anymore.
No.
Yeah.
No.
Yeah.
Well, as you know, blue was actually the color of girls for about 100 years. Yeah. So, it's a bit of a bad choice.
Blue was the color of girls.
Blue was the color of girls from about the 1860s, 1870s through to about the 1940s, 1950s, and pink was the color for boys. And it only swapped after the Second World War, largely at the hands of clothing retailers.
Well, I'm leaving that part into this conversation. Okay, let it not be said you don't get cool bar trivia from Malecare. So thank you very much, and welcome to our faculty. Okay.
Okay. Bye.
Bye.